Assalamu alaikum. Our seminar today is about maxillary sinus disease and its relation to the oral surgery. It will be presented by me, Diyar, and my colleague Dua Salim. First, what is maxillary sinus? It is one of the four paranasal sinuses, which are the sinus located near to the nose. Here in the picture, we have frontal sinus, sphenoid sinus, ethmoid sinus, and the maxillary sinus. The maxillary sinus is the largest of the paranasal sinuses. The two maxillary sinus are located below the cheeks, above the teeth, and on the both sides of the nose. The sinus are small air-filled holes found in the bones of the face. Second, we have the anatomy of the maxillary sinus. First, we have the base, which is formed by the lateral wall of the nose, and the apex, it is projected laterally into the zygomatic process of the maxilla. The roof, which is the floor of the orbit, the floor, which is formed by the lateral hard palate alveolar process of the maxilla, the anterior wall, which is the facial surface of the maxilla, and finally the posterior wall, which is the infratemporal surface of the maxilla. The blood supply. There are three main arterial supply to the maxillary sinus, which is the first, the posterior superior alveolar artery, the second, which is the infraorbital artery, and the third, which is the posterior lateral nasal artery. And here, the posterior superior and infraorbital artery are direct branches of the third portion of maxillary artery, which is the pterygopalatine artery, which it is in turn eliminated from the external carotid artery. The posterior lateral nasal artery, it is a branch of sphenopalatine artery, which is also come off the maxillary artery. Here in the picture we have maxillary artery, and here it is the infraorbital artery. The venous drainage, the vein accompany the artery and drain into the anterior facial vein and then to the pterygoid plexus of the vein. Here we have facial vein, and here is the drainage to pterygoid plexus in the infratemporal fossa. Nerve supply. Nerve supply to maxillary sinus is from the superior dental nerves, which is anterior, middle, and posterior, and the greater palatine nerve. These are branches of maxillary division of the trigeminal nerve, which is the fifth nerve. Their pathway are of surgical importance because as there is a possibility of the damage to any of these nerves while doing surgical procedure on the anterior and posterior wall of the antrum. Lymphatic drainage. The lymphatic drainage of maxillary sinus is through the infraorbital foramen or through the ostium and then to the submandibular and deep cervical lymph node. Here we have submandibular lymph node, and here we have inferior deep cervical lymph node, and here the superior deep cervical lymph nodes. The function of maxillary sinus. First, it's impaired resonance to the voice, increase the surface area and lighten the skull, moisten and warm the inspired air, filter the debris from the inspired air. Sinuses are located in front of the forebrain, olfactory region, etc. They create air budding to provide thermal insulation to the important tissue mentioned above. The clinical examination of maxillary sinus. First, we have extraoral examination and intraoral examination. The extraoral examination, which is include the pain and tenderness. Here we have tenderness, swelling over the prominence of the cheekbones. The intraoral examination also we have bone and tenderness, swelling over the maxilla between the canine fossa and the zygomatic buttresses. And here we have transillumination. The affected sinus show decreased transillumination of the light due to the accumulation of the fluid, debris, pus, and thickening of the sinus mucosa. Radiology of maxillary sinus. The radiological examination, it is important to the clinical examination of maxillary sinus. It provides adequate information to either confirm or rule out various pathological process involve the maxillary sinus. Radiographs useful as the follow, which is the extraoral view and intraoral view. First is the extraoral view, which is occipitomental, submental vertex, orthodontography, and lateral skull, and here computed axial tomography. The intraoral view, first we have lateral occlusal, periapical view, and the occlusal view. Here we're gonna start with the disease that affect the maxillary sinus. First, we have infection of maxillary sinus of odontogenic origin. It's called odontogenic sinusitis. Odontogenic sinusitis is the inflammation of a mucosa of any of the paranasal sinuses. The inflammation of most or all the paranasal sinus, stimulously known as sinusitis. The maxillary sinusitis is usually odontogenic in origin because of its close proximity with the maxillary teeth. The condition, if not treated, may spread to involve the other sinuses. The etiology first, it may be because of the infection, periapical abscess spreading into the maxillary sinus, other infection following common cold, upper respiratory tract infection, etc. Here we have periapical infection spread into the maxillary sinus. Or it may be caused by trauma, which is the fracture of the enteral floor and walls, or allergy, or neoplasm and infected cyst of odontogenic origin. Here we have infected odontogenic origin cyst, which is the intergerous cyst with the maxillary sinus arising from ectopic third molar, or intraoral communication and fistula, or displaced tooth or root. Here we have root extended into the maxillary sinus. In case the ostium of maxillary sinus get blocked, the mucus secreted by secretory cells of the walls get collected and bacterial growth then produce an infection. Here we can divide the maxillary sinusitis into two classifications, which is acute and chronic. Also another cause, it is spread of infection to the maxillary sinus from the apical abscess. Here in the picture we have the apical abscess spreading from the tooth into the maxillary sinus. The most common cause of spread of oral infection to maxillary sinus, it can be attributed to the periapical abscess. 15 to 20% the maxillary teeth with the roots in close proximity to the floor of the antrum most likely involved in causing such infection are first and second molar. That means it is the first and second molar, the most common teeth that involve in the spread of infection to the maxillary sinus. The clinical feature, we have severe throbbing pain. Patient complain of full pus running down a nostril or presence of unpleasant taste or smell. The tooth is periodontally involved. It may be feel loose. That means there is a mobility in the tooth involved with the maxillary sinusitis. There is only a slight swelling of the cheek. Periapical lucency near to the one of the right maxillary molars. Yellow arrow, note the mucosa thickening in the right maxillary sinus. A green arrow, we have mucosa thickening here as a result of adjacent inflammation. The management is the extraction of the appendic teeth. It is recommended that the socket be covered with a complete soft tissue closure with the antibiotic prophylaxis and taken for at least 5 days post-operatively, and also we give him a decongestant in form of nasal inhalation or drops. First, we're gonna explain the acute maxillary sinusitis. It may be suppurative or non-suppurative inflammation of the internal mucosa. We also have the extraoral examination, like here, tenderness, and also we have here a swelling. And we have intraoral examination that show oral enteral communication or also swelling intraorally. The symptoms of acute maxillary sinusitis. First, the patient may give a history of cold to 3 to 4 days before the acute attack. Here, cold does not go away or get even worse. And also he have nasal blocking, thick mucopurulent, full smelling, discolored nasal discharge may follow, post-nasal discharge with the constant irritation requiring a clearing of the throat, and cough. Also, cough we have secondary to the nasal discharge may lead to the pharyngitis. Also he feel a heavy feeling in the head, so he have headache, constant throbbing pain in the upper back of the cheek, and maxillary teeth in relation to the maxillary sinus or sinusitis on the affected side may be painful. The management. First, we have a classical enteral regimen, which is include the drinking plenty of water, bed rest, and maintain the oral hygiene for at least 7 days. Second, we have antimicrobial. The most suitable against common enteral pathogen are macrolide, which is erythromycin 250 to 500 milligram every 6 hours for 5 days. Also, broad spectrum group, which is amoxicillin 250 to 500 milligram 8 hours for 5 days. And also we have decongestant. These take care of nasal congestion, which is a nasal drop or spray. For example, ephedrine sulfate here, 0.5 to 1% in normal saline, 6 hours. Also, we have xylometazoline hydrochloride, 0.1%. And finally, we have non-steroidal anti-inflammatory analgesic, which is aspirin, paracetamol, and ibuprofen. Second, we have the chronic maxillary sinusitis. The chronic maxillary sinusitis may be due to the persistent dental focus, chronic rhinitis, chronic infection in the frontal or ethmoidal sinus, allergic condition, etc. Let's watch this video.
Chronic sinusitis is one of the most frequently diagnosed chronic conditions, affecting millions of people each year. Sinusitis is a condition in which the sinuses become inflamed and swollen. Swollen sinuses are not able to properly drain, causing sufferers to experience pain, tenderness, and swelling around the eyes, cheeks, nose, and forehead. In cases of chronic sinusitis, these symptoms may last for more than 12 weeks, or they may recur regularly. Cases of chronic sinusitis often have underlying causes, such as nasal polyps, a deviated septum, or allergies. And treating the underlying cause can help to address sinusitis symptoms. If your sinusitis symptoms last longer than 2 weeks, your doctor will be able to recommend tests and treatments to diagnose and address the underlying causes of your condition.
The symptoms of a chronic sinusitis. First, the condition sometimes is asymptomatic. Pain and tenderness in the area of the antrum found usually in acute exacerbation. Unilateral discharge through the posterior nares. A fetid odor with the bad taste in the mouth. Also, he have a pressure or pain above the air bro. Also, he have thick nasal drainage. Reduced or absent sense of smell or taste. The diagnosis. The diagnosis is based on the history of repeated attack of acute mucopleurant rhinitis. Second, long-standing nasal or post-nasal discharge. Anterior rhinoscopy. Here we have anterior rhinoscopy. It shows nasal congestion and mucopleurant material in the middle meatus. And also an inspection of the oropharynx reveal a descending pharyngeal exudate, presence an obvious orointral fistula may be also here. Transillumination. The sinus reveal radio opacity on the affected site. Here, radio opacity on the affected site. And also radiography. Radiography. The findings are the presence of a fluid level, thickened lining membrane, opaque area space may be enclosed the polyp associated with the mucosal thickening. In case in the presence of the tooth or root, the characteristic outline is seen within the sinus. Here we have two pictures of CT scan. First, here there is an complete obliteration of the maxillary sinus, and here there is a thickening in the maxillary sinus mucosa. So, in the right picture, the periapical abscess of the first upper left molar tooth with the associated complete obliteration of the left maxillary sinus. And here the CT scan show a chronic sinusitis, not the mucosal thickening in the maxillary sinus. So there is a difference between the obliteration and the thickening of the sinus mucosa. The management of a chronic sinusitis. The management requires eradication of related dental complication. If the chronic sinusitis is caused by chronic periapical infection, then the affected tooth must be extracted and the socket closed surgically completely, as there is a risk of orointral fistula formation. Here we have a surgical closure of the socket with the palatal flap. If there is already a communication with the maxillary sinus, if the blood clot failed to organize and the socket get infected, then there will be a persistent chronic maxillary sinusitis. Here there is a management of a chronic sinusitis when the cause is the foreign body that is inserted inside the maxillary sinus. Such a tooth or root in the sinus, it is necessary to remove these foreign bodies before considering any form of the treatment. Concurrent presence of intrapolyps should be removed. The intral air space gently irrigated and closure of the wound is effected. Routine post-operative treatment with the antibiotic, decongestant, and analgesic to be given. Here there is a 2 OPG. First, is the presence of the foreign body or root of the tooth in the maxillary sinus, and here after the removal of this foreign body from the maxillary sinus. Also, we have Caldwell Lock procedure. The Caldwell Lock procedure, it is initiated by the intraoral incision, is carried out along the alveolar ridge. The mucoperiosteum is then detached and retracted sufficiently. And here there is a bony opening. Perforation into the sinus is made about approximately 1 centimeter above the root apex of the first premolar using a small gauge, and then it is enlarged by an educate instrument until it is large enough. The surgical instruments are inserted here in the second picture. The surgical instruments are inserted through this bony opening, and necrotic tissue, granulation, and disease enteral mucosa are peeled off and totally removed. We should give a great attention is required to prevent injury to the infraorbital foramen, the nerve and the vessel around the eyes, the dental root apex. Then a new opening for drainage through the nose is created. Initially, a piece of gauze with adrenaline should be inserted into the nose. After nasal mucosa is cut and removed, creation of an opening from the intrum to the nose is confirmed. The hole is enlarged sufficiently using grasp or other instrument. Here, after careful inspection of the entire field of operation, a long stick strip is inserted into the intrum from the nose to maintain the entire width of the nasoantral window. Finally, the oral flap is closed and sutured. Also, the management of a chronic maxillary sinusitis, if there is a presence of a chronic pyogenic sinusitis subsequent to the oroantral fistula, they require surgical closure of the fistula. The polyp found on the operation site, here there is a polyp on the operation site. It should be removed preoperatively if the intrum is found to be full of pus, like here, full of pus. It should be irrigated through the fistula on daily basis with warm normal saline or betadine, or when the intral washout appear to be clear, the fistula should be repaired and the routine post-operative measure is instituted. So in cases when there is no oroantral fistula present, but there is a chronic maxillary sinus non-responsive to other conservative regimen, then surgical drainage should be considered. First, the procedure for surgical drainage is through a topical anesthesia ointment is applied on the cotton wool, which is inserted along the nasal floor adjacent to the lateral wall of the nose near to the inferior turbinate. A sharp trocar and cannula is then introduced along the floor of the nasal cavity inferior to the inferior turbinate, and the thin medial wall of the intrum is punctured. The trocar is withdrawn and the pus can be drained under the pressure through the suction tip. Warm saline irrigation should be carried out daily till the symptoms settle down, as here in the picture. Trocar is inserted through the nostril to the maxillary sinus for surgical drainage and irrigation. Finally, we have antral lavage. Antral lavage is largely absolute surgical procedure in which a cannula is inserted into the maxillary sinus via the inferior meatus to allow irrigation and drainage of the sinus. Lavage is also called proof puncture, as the presence of infection can be proven during the procedure. There is often a multiple repeated lavage can be subsequently required to allow full washout of the infection. This procedure is indicated when there is acute and chronic maxillary sinusitis not responding to the medical treatment, or there is a chronic infection not responding to the treatment, or irrigating and wash out collected pulmonary secretion, dental maxillary sinusitis, or oroantral fistula if associated with the sinusitis, and finally acute bacterial sinusitis, though it is indicated only in severe cases, not as a regular treatment. And thank you very much.